So today, November 17th, 2021, Leukemia Management in North Carolina, updates for 2021 with Matthew Foster, MD. Matthew Foster's MD's research interests involve clinical and translational research in the hematologic malignancies. In particular, he is involved in the design and conduct of phase 1 and 2 clinical trials of novel agents and drug combinations for patients with acute leukemias, myelodysplastic syndromes, and myeloproliferative neoplasms. Furthermore, he has particular interest in incorporating correlative science studies that can predict biologic response of drug toxicity in patients with hematologic cancers, including both host and tumor genetic variables that predict response to anti-leukemic agents. Dr. Foster, welcome. Thank you so much for being here today.
Thanks for having me, Tim.
Absolutely. And what's maybe one thing you can share with us outside of your professional bio?
Well, we're going to talk a little bit about the pandemic. So I was thinking about what I've changed during the pandemic, and one of the things that I've really enjoyed activity-wise is started mountain biking, and particularly some trails around my house. I've really discovered part of the natural beauty of North Carolina in the Piedmont here that I really didn't appreciate before. So that's a little bit about my recent interests. So.
Good for you. Great something to take up, and boy, you couldn't pick a better time of year to be doing it right now. It's just amazing out there. As of today, the fall colors. All right. I mentioned poll everywhere. Our first question, we always try to make it a softball. Leukemia is cancer of blood-forming tissues, including bone marrow. That'll be a true or false. This is just a screenshot, but we'll put up the actual slide in just a moment. I will say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, NPH, and CPD staff have no relevant financial interests or financial relationships with commercial interests as defined by the ACCME. Matthew Foster, MD, has no relevant financial relationships with commercial interests as defined by the ACCME. Matthew Foster, MD, has relevant financial relationships with Macrogenetics, Daiichi Sankyo, and Agios. These relationships have been mitigated and have not influenced the planning or implementation of this activity. All right, and we're already getting responses to our poll everywhere question. Dr. Foster, maybe we'll give them 10 more seconds, and then you can let them know how they're doing. But I do already see a theme emerging here.
Looks like everyone's A+.
Awesome. Thank you so much. And thanks to our audience for jumping in and responding. All right. Without further ado, 2021 updates in leukemia. No longer back in my day with Matthew Foster, MD. Dr. Foster, I'll let you take it from here.
Well, thanks for having me, Tim. Before we get to the content, I do want to have one other disclosure that I am going to talk about off-label use for an unapproved drug called magrolimab later in the talk. So thanks again for having me. So I want to dedicate this talk to my son, who I'm learning every day what it's like to have a preteen. And one of the aspects of having a preteen is that they like to make fun of their parents, and I think in particular their father for some reason. And one of the things that he makes fun of me for is saying back in my day with an old man accent or an old man type voice, and something I really actually never say, but it doesn't matter to him. He still kids me about that. So every day in leukemia care, I'm really happy about recent advances, and we're going to talk about kind of 2021 advances in comparison to what things were like back in my day. So outline here is that we're going to talk about AML, including some aspects of improving care for older patients, high-risk AML patients, and the advent of some oral therapies that we didn't have available until recently. We're also going to talk about a couple of new drug approvals, one for ALL, specifically CAR T cells in adults, and a new class of drugs for CML patients. And then finally, I was hoping that we wouldn't have to talk about this in late 2021, but unfortunately, our leukemia patients still need to take caution, and we need to help take care of them and protect them during the COVID-19 pandemic. So we're going to talk about the intersection of the pandemic and leukemia care. So next slide. So first off, AML. Next slide. So back in my day, we didn't really have effective treatments for older patients with AML. So these are Kaplan-Meier survival curves generated from patients enrolled in cooperative group studies across the United States. And each curve represents patients in a particular age category treated in a specific decade. So on the left, you see the under 55-year-old population. And every decade, there were some advances in outcomes. And we hope that this is continuing, not just through the 1990s, but the subsequent decades. And the main reason that outcomes were better were not new drugs for these patients, but new application of allogeneic stem cell transplant, transfusion practices, and antibiotics. But unfortunately, without any new drugs to treat older patients, we really didn't have advances in outcomes over those decades. But I'm happy to say and show you shortly that I hope this is improving. Next slide. So why is it important to talk about older adults with AML? Well, simply put, most patients with AML and its precursor diagnosis, MDS, are retirement age or older. So the average age is between 65 and 70 at the time of diagnosis. And unfortunately, the trials that were developed years ago for AML were only testing drugs in younger patients. So our standard definition kind of for cutoff between older and younger is either 55 or 60 years old. And so by definition, we really weren't studying the therapies in the majority of the population with these diseases. Next slide. One of the reasons that older patients differ from younger patients is not just that they can't tolerate therapies or have comorbidities, but really they have different diseases. One of the ways we describe biology of AML is by genetics, and the oldest way to do this is by looking at chromosomes or at karyotype cytogenetics. And their characteristic unfavorable or adverse prognostic genetics, and they're also intermediate and favorable. And so as patients go through those age cohorts, younger patients are more likely to have favorable genetics and respond well to chemotherapy than older patients. And older patients are more likely to have these complex, really adverse prognostic genetics. And so the disease biology is different in older and younger patients. Next slide. This is, the discrepancies in research outcomes in older patients and the knowledge that the most unfavorable biology frequently occurs in older patients has really led to a lot of nihilism in the broader oncology community. There are several studies that have shown that older patients are less likely to get any treatment than younger patients. However, we know from data generated years ago that some treatment, even the lightest treatments that can be tolerated by older patients, are better than nothing, or better than supportive care in terms of a number of variables. So on the left, you see from the UK a study that compared LDAC, or low-dose cytarabine, which is a very palliative, well-tolerated therapy for anyone, versus just best supportive care, so supportive care without chemotherapy. And on the right, you see curves of azacitidine, a DNA methyltransferase inhibitor that's often used in the United States, also very well tolerated. So you can see the survival curves there that either of these treatments leads to slightly better survival, doesn't cure the disease, but slightly better survival than supportive care only in older patients with AML. But only about 1 in 5 patients enters remission, and there are still some patients who suffer early death, largely due to infectious complications. So fortunately, we have a new drug on the scene, and I believe that probably in the most recent talks about AML, we have, in this series, we have hit on venetoclax, but it's been such an important advancement for older patients with AML, I want to give you an update about it. So venetoclax is an inhibitor of BCL2. BCL2 is a protein in this BCL family of proteins like MCL1, BAX, and BAC. And these are proteins that regulate the programmed cell death or apoptosis in any cell in our body. And in leukemia, it turns out BCL2 is often overactive and very important in prohibiting these cells, leukemia cells, from dying and living, and the cells live longer. Venetoclax was first approved in chronic lymphocytic leukemia, and then a couple of years ago, it achieved accelerated approval for AML in older adults in combination with azacitidine or low-dose cytarabine, those backbone therapies that I showed you a couple of slides ago. And so anytime a drug is approved on an accelerated pathway, it has to undergo a confirmatory study comparing it to an old standard. And the next slide will show you what that is. So this phase 3 study compared azacitidine plus venetoclax with azacitidine plus placebo in patients over age 65 with comorbidities or any patient over age 75. And the survival curves here show that there was a survival advantage to patients who received the 2-drug therapy rather than the 1-drug therapy. And this translated into about a median 6-month benefit in survival. And so clearly we still have room to go. We still have improvements that are out there that I think we need to chip away at. But what's also important is this improved remission rates. And for any of you who've taken care of leukemia patients, you know that someone who's in remission has a better quality of life than patients who are not in remission. So drastic differences, 2 or 3 times the remission rate in the 2-drug therapy compared to azacitidine. And this translates into lower burdens of both red blood cell and platelet transfusions. And these are very important measures for patients and quality of life. So we'll go to the next slide. Nothing good comes without a cost. And of course, the 2-drug therapy in older adults, not surprisingly, results in a higher number of side effects. And in particular, the problems tend to be early on in the therapy. This prolongs the myelosuppression, so the bone marrow suppression, and leads to higher grades and longer duration of low platelets, low white cells, and the consequences of low white cells, infections, and as azacitidine venetoclax compared to azacitidine placebo. So a lot of what we do here at a leukemia center like UNC is kind of work through the management and support patients through the early going on these drugs to make sure that we're starting and stopping and adjusting the doses accordingly based on their myelosuppression and related side effects. So it's really important to start this therapy in a leukemia center, even though if someone's doing well on it, it can be continued in a community oncology setting. We always like to analyze outcomes in leukemia trials and AML trials according to the genetic subgroups because, again, this really defines the biology of the disease and what we can expect for the patient. And these subgroup analysis identified patients with kind of the less adverse genetics, so the intermediate cytogenetic group, and particular mutations such as the IDH1 and IDH2 mutations that tended to do better with venetoclax and derive more benefit in terms of survival. There are a couple of groups, notably, that didn't seem to benefit, those with mutations in a gene called and with mutations in TP53. You see that NPM1 mutated patients didn't seem to have a benefit either, but that's actually because that group tends to be sensitive to chemotherapy to begin with, and those were relatively small numbers. So I have a number of patients with NPM1 mutations that are doing quite well on this combination. So certain subgroups still have a long way to go. I'll go to the next slide. And so I want to talk a little bit, not about what has recently been approved, but where 2021 stretching on to 2022 and beyond, where I think things are going in the subgroups of patients that may not be helped by azacitidine and venetoclax. So I imagine that we've also heard in this series a lot of good news about immune therapies in solid tumor patients. And what most of those therapies are checkpoint inhibitors. So the checkpoint inhibitors that have been developed thus far interrupt, actually most of them interrupt an interaction between PD-1 on lymphocytes and PD-L1 on cancer cells. And this interaction is key for the cancer cells to evade the immune system. And when that interaction occurs, the cancer cell evades immune surveillance, and by using drugs that block that interaction, the immune system can be more active against the cancer. And those type of checkpoint inhibitors have been, are still being investigated in hematologic malignancies and leukemia, but their role is a little bit less clear. But what appears to be more exciting for AML patients and MDS patients is a different checkpoint. And what you see here is an interaction between a protein called CD47 on the cancer cell and my favorite cell back from medical school called a macrophage, because it's really easy to understand what a macrophage does. It eats other cells. So some people call this a don't eat me signal, and it really makes sense what it does. So CD47, when it interacts with SIRP alpha, tells the macrophage not to eat the cell. And so this antibody, and the one furthest in development is called magrolimab, blocks the SIRP alpha CD47 interaction and allows the macrophage to eat the bad guy. So I really like that imagery. So this has been developed and is being tested in a number of different cancers, but perhaps the most interesting early outcomes come from a trial that was presented last year at the American Society of Hematology meeting, and we will get updates for soon, hopefully, which is on the next slide, that investigated magrolimab in a small cohort of patients with TP53 mutations who had AML or MDS. And about 2/3 of them responded, and what's more important is that these responses tend to last more than 6 months, which is, the azacitidine venetoclax, the response rates are about 50% and only last about 6 months. So these are encouraging early results that will need to be investigated in more trials that are ongoing, some of them that we've been a part of here at UNC for both AML and MDS. Another positive development for older patients, in particular with AML and MDS, are different hypomethylating agents or DNA methyltransferase inhibitors. Think back to the azacitidine slide I showed. This is probably the most commonly used DNA methyltransferase inhibitor, or HMA. And one of the bad, these are well-tolerated drugs, but one of the inconveniences is that they have to be delivered by sequential daily injections or infusions over 5 to 7 days per month. When you add those 5 to 7 days to a patient who is dependent on transfusions and maybe 75, 80 years old, that's a lot of burden of care to be in the infusion center, sometimes half of the days out of a given calendar month. So the holy grail has long been to develop oral hypomethylating agents. But this enzyme called cytidine deaminase is present in the GI tract and causes breakdown of these drugs. So just taking a pill has not been incredibly successful in past trials. But a company developed an inhibitor of that enzyme called cedurazidine, and this allowed a bioequivalence study. The curves on the right you see are the blue curves are the pharmacokinetics or drug levels according to time for IV administration of decitabine. And the red curves are different oral doses of decitabine plus the stabilizing drug cedurazidine. And you can see that these kind of approximate one another. And so this drug was actually approved on the basis of this bioequivalence study. Keep in mind that long-term outcomes really haven't been compared between IV and oral formulations. But in the appropriate patient, I think that as long as they understand that long-term outcomes have not been compared, this represents a way to deliver these therapies at home, whereas we were typically bringing people into infusion centers beforehand. Another example is also oral azacitidine. This was studied in a different manner. This was studied in a large randomized controlled trial of maintenance therapy for AML. Maintenance therapy has, there was previously no standard maintenance therapy for AML patients. And this was a study that enrolled patients above the age of 55 with AML who had gone through induction, and most of them in this trial also went through some consolidation chemotherapy and were in remission, but not candidates for stem cell transplant, which is what we often do in some patients. So in these non-transplant candidates, maintenance therapy was employed with oral azacitidine, 300 milligrams for 14 days on and 14 days off until they progressed. And it turns out that this certainly reduces or delays recurrence of the leukemia and prolongs survival. So this oral hypomethylating agent is now a standard of care for that older population who's not a transplant candidate to try to preserve their quality of life, preserve their remission, and prolong survival. So this brings us to our first poll everywhere question. So which mutation in AML signifies that a patient is least likely to benefit from venetoclax-based therapy? Are they an IDH1 mutation, IDH2 mutation, an NPM1 mutation, or a TP53 mutation? So everyone who's answered so far got it right. So so A+. So there's the correct answer. Hi, Adam. Good to see you. We're going to move on to another acute leukemia, ALL, and specifically CAR T cells that were approved for adult patients. So back in my day, we only had CAR T cells for children. Now this back in my day is not that long ago. So, so many of you have probably been following the popular press over the last 10 years. It's hard to believe it's been almost 10 years ago that some of the early successes in children happened with CAR T cells in ALL, where these children had really been treated with every therapy known. And some of the children were actually cured with CAR T cells, have had long-term remissions, which just doesn't happen with any other drug. And in 2017, a CAR T cell product was approved for children and young adults up to age 25. But a number of toxicities led to cold feet, really, in developing these for adults with ALL. So to kind of level the field, let's talk about what a CAR T cell is. So CAR T stands for chimeric antigen receptor modified T cell. And this takes the best properties of monoclonal antibodies, which are the recognition of antigens on the surface of cancer cells, and fuses them to a part of the cellular immune system in a T cell called the T cell receptor complex. And so this allows really direct communication between the two arms of the adaptive immune system, the humoral, the antibody-mediated immune system, and the cellular immune system. And so what happens is that the T cell, as you can just click the next little part of this slide, the T cell engages with the tumor antigen and results in cytotoxicity. As you can see, these have been in development for many, many years and have really just now hit the clinic. So we can go to the next slide. There are some real and theoretical advantages of CAR T cells over other immunotherapies. One major advantage that patients really like is they have a single dose. They don't have to take a drug week in and week out. They just get one dose. And then there's this kind of living drug within them that is a single T cell can be a serial killer and target multiple cancer cells, and they could expand in response to engagement with the cancer antigen. Here's how they work for patients. So the first step is that T cells are drawn out of the body by a leukapheresis procedure and are activated in the presence of some antibodies. The second step is that the cells are exposed to a viral vector that transfers the gene for the chimeric antigen receptor. Third step is expanding the T cells in a broth that includes some cytokines or proteins that encourage T cell growth. As you can see, these T cells have developed from just patient T cells to patient T cells with this chimeric antigen receptor on them. Fourth, they are grown some more, and a lot of quality control steps are performed in a lab. And so you can see this takes several weeks before the cells are ready for the patient. So it's one of the downsides of this therapy. But after they're ready, patients get lymphodepletion chemotherapy to allow them to not be rejected by the immune system. And then they're infused into the patient. I want to touch on some important toxicities that have really, some of which have hampered the development of these cells for adults with B-cell ALL. When I think about this, I think about early toxicities, medium and late toxicities. Probably the most important early toxicity is that any biologic agent like monoclonal antibodies can result in an allergic reaction or anaphylaxis. And so that we don't see very often, but it can happen. And then within the first couple of weeks to months, or to first month, patients can have, at the time of this expansion of the CAR T cells in the body, something called cytokine release syndrome, where they have, it's almost like a really bad case of the flu, fever, muscle aches, but in severe cases can have hypotension, tachycardia, hypoxia, and organ dysfunction. You can also have this condition called ICANS, or neurologic toxicity. ICANS stands for immune effector cell associated neurotoxicity syndrome, and we'll get into more details about what that is. Another toxicity that can happen is called on-target off-tumor toxicity, where an antigen that's on the cancer cell is also expressed in other cells in the body. And an example here with CD19 CAR T cells, normal B cells that produce the antibodies that protect us from infections can be killed by the CAR T cells and result in low immunoglobulins and as this immunodeficiency as a result. I won't touch on the insertional oncogenesis because this is a theoretical concern that really hasn't played out. So there's always been a worry that the virus could introduce a cancer gene, but in the CAR T cells that have been tested, this hasn't been seen at all. So a little bit more about cytokine release syndrome. This is an example of what happens in the lab over time. So you can see the flow cytometry plots across the top of the screen there. On the left is the infused product. In the little black box are the number of CAR T cells. Those are the treatment there. And as you can see, it takes about a week for those to expand and be detected in the blood, and then they kind of gradually drop off over the remainder of the month. But as they expand to their peak population, you see these cytokines down at the bottom, where interleukin 6 and interferon gamma peak around 1 week in this individual patient, and that's responsible for these fevers and hypotension and other side effects. The symptoms usually present as fever alone early and then can escalate from there. The timing of these really depends on which CAR T cell product someone gets. Some of them tend to expand very early, resulting in early cytokine release syndrome like a day or two later. And sometimes it takes about a week to 10 days. This hardly ever happens after 3 weeks. An interesting finding is that we want to see some of this. That's a sign that the cells are expanding and doing what we think they're going to do. So most patients who are destined to respond will have some degree of cytokine release syndrome, but you really don't need to have a severe case of it for patients to get a good response to the cell therapy. So a part of our role as specialists is managing the CRS to make it tolerable for the patients. Another, we mentioned the neurotoxicity called ICANS, and this can early on look very subtle. It can be just kind of an alteration in sleep-wake cycles, or it can be subtle word finding or handwriting difficulties, but can also be very dramatic like coma, seizures, or focal stroke-like symptoms. Sometimes it comes along at the same time as cytokine release syndrome, and sometimes it happens at a separate time by itself, but usually only early on within the first month to 6 weeks. most of the cases, in almost all cases, these are reversible, and you don't need to see this to see a response in the disease that you're treating. One of the reasons that development of these in adults was slower than children, is that there were a couple of adult cases of cerebral edema that were fatal in one trial in particular. And so that really slowed things down for good reason. So why does ICANS happen? Well, for one thing, you can't actually see CAR T cells in the spinal fluid, so we know they get into the beyond the blood-brain barrier. But we think that this toxicity is probably due to some CD19 being expressed on a cell that supports the endothelium or the blood vessels in the nervous system, called a mural cell. And because of that CD19 expression, the cells can injure the vessels, causing blood clotting and leakage of blood called a microangiopathy in the nervous system. And you can actually measure in patients with ICANS changes in the blood clotting parameters like the D-dimer, platelets, or fibrinogen in patients that have ICANS. So we think that this is probably in play. Fortunately, these toxicities, we've learned over the years how to manage these well, and this allowed completion of a phase 2 study in relapsed and refractory B-cell ALL. It was just published this year, and just a few weeks ago led to the approval of brexacabtagene autoleucel. There will not be a pronunciation test, but I want to show you some of the results from this trial so that you understand what this is. I want to show the flow through the trial. So you see it on the left, 71 patients were enrolled. This took several years to enroll, to select the best patients for this. And of those 71, 16 did not end up getting cells for one reason or another. Sometimes the disease is too aggressive and doesn't allow that time for the cells to be produced and given. And sometimes there are other problems that arise. And so this amounted to about 22% of the patients not enrolled in the trial not getting cells. And I think this highlights the difficulty in ALL. That number is a little bit higher than what you see in CAR T cells that have been developed for B-cell lymphomas, which typically are a little bit more forgiving in terms of their pace of progression and allow this time to safely pass before the cells are ready. But the ones who did get the cells, the majority of them, so 71%, entered remission, and most of those patients were what we call MRD negative, which means that you can't use flow cytometry. So if you're using flow cytometry, you can't detect the cancer cells at all. That's much more sensitive than just looking at the bone marrow under the microscope. So these are very deep remissions, and as we'll see on the next slide, they're reasonably durable as well. The patients in remission had a median duration of remission of over a year, which is impressive. But as you can see on the survival curves, there's still some people relapsing out beyond a year. So I think this really deserves further follow-up to see if, like kids, some of these patients are cured with CAR T cells alone, or should we really think of this as more of a bridge to another therapy like a stem cell transplant? On the left, you see the toxicities that we highlighted early on, and you can see really that the majority of patients have CRS and or ICANS. Fortunately, most of these are the lower grade versions of these side effects, so fevers and maybe mild alterations in thinking. But these are scary toxicities nonetheless that really need to be managed in a multidisciplinary specialty center. So these cells are still given in centers that have leukemia programs and stem cell transplant programs. On the bottom, you see that there was a grade 5 or fatal cerebral edema that developed after ICANS. So these are really therapies to be respected. So this brings us to our second poll everywhere question. So which of the following toxicities of CAR T cells for ALL is likely to develop later than 1 month after cell infusion? Is it cytokine release syndrome, A, seizures, hypogammaglobulinemia or low immunoglobulins, or neutropenia? Give everyone a couple of seconds here. So interestingly, so cytokine release syndrome will typically happen in the first couple of weeks. Someone did answer neutropenia. If neutropenia develops, it usually develops early, but it can persist beyond a month. But the one that really develops a little bit later are the low immunoglobulins. So the hypogammaglobulinemia tends to be a later effect. So it looks like there may be some technical issues with the poll everywhere, but hopefully we can provide some feedback in real time by just talking about the questions. So, next, we want to talk about a new class of drugs for CML. So back in my day, we only had one good drug for CML, and that was really a long time ago. Almost 20 years ago is when imatinib was developed for CML. Hallmark of chronic myeloid leukemia is the Philadelphia chromosome, which is a translocation between genetic material on the 9th and 22nd chromosome, which causes the development of this fusion protein called BCR-ABL. It is a kinase, or so a protein, an enzyme that transfers a phosphate group to a substrate, and that substrate signals downstream for uncontrolled growth. So this is a molecular switch stuck on the on position, and every drug until now that has been developed for CML is a tyrosine kinase inhibitor that blocks the binding of ATP to that little pocket and results in abrogation of that signaling. One of the limitations of CML therapy has been the development of mutations that block the entry of imatinib and its second generation drugs to that pocket. And on the left, you see a heat map. So the green color means that there's sensitivity to the drugs that are listed along the top of the graph, the top of the table. And on the left side of the table, you see individual mutations. And so green is good and red is bad. And you can see a stark red line across this T359 mutation. And that's because none of these drugs fit in the pocket of the protein when that mutation occurs. And then several years ago, this drug ponatinib was developed that is kind of a slender shape and does fit in that pocket, but has some specific toxicities, namely arterial blood clots and pancreatitis, which are both, can be severe and life-altering complications. So this is a drug, that is kind of has been our last line drug and has some limitations. And so we're glad that a new class of therapy is developed, and we'll see the mechanism of that on the next slide. So asciminib is the name of the drug, and on the left of this figure, you see that in non-fused ABL, which is not fused to BCR, the end of the protein is called this myristylated N-terminal, and that toggles back and forth into this little cleft here, and results in an equilibrium between inactive and active enzyme. And so that's kind of the natural state. When you have BCR-ABL, the BCR protein blocks the end of that so that there's no toggling back and forth. And that's why it's kind of this switch stuck in the on position. And it turns out that when asciminib enters that cleft, it results in restoration of that equilibrium between active and inactive state and allows more regulation of myelopoiesis in that situation. And so this theoretically has nothing to do with that T359 mutation. So when this drug was developed, one of the first studies that we'll see on the next slide looked at this in the T359 mutant population. And the majority of these patients had actually been treated with ponatinib. So they really had no other therapies that were available to them. I'll walk you through this as a somewhat complicated display of the data. So these are the patients in the first studies of asciminib that had T359 mutations. Across the top, you see the proportion of BCR-ABL transcripts, so the leukemia gene in the blood. On the right, you see the highest proportion, greater than 10%. On the left, it's lower proportions. So the patients in the red boxes at 6 months on the top there were those who had greater than a 1 log reduction, or chopped a 0 off their number, essentially. So about half of the patients had 1 log reduction or more. And at 12 months, the proportion was same, and even some patients were deepening with a greater than 2 log reduction. And this is, you'll just probably have to trust me on this, that for patients without any other therapeutic options, this type of activity is likely to translate into good clinical control of their disease, at least in the short term. This is also studied in another scenario that you'll see on the next slide, which has not been published yet. But these were patients who did not necessarily have the T359 mutation, but had been treated with 2 or more prior therapies. Apologize that the slide came out a little bit blurry there, but I'll explain what we're seeing is that patients who were resistant to 2 or more therapies had a higher rate at 24 weeks of what's called major molecular response. Major molecular response correlates very well with long-term survival from CML. And so in these patients with resistant disease, this was compared against another drug called bosutinib. This was superior with regard to achieving the major molecular response. And on the next slide, we'll see also that this was associated with better tolerability, in that adverse events tended to be lower grade with asciminib compared to bosutinib, and fewer rates of treatment discontinuation due to side effects. So this was presented last year at American Society of Hematology, and this drug was just approved for both T359 patients and these patients who failed 2 prior therapies or more just a couple of weeks ago. So this is very hot off the presses. Hasn't actually been published yet. So the last topic I wanted to discuss also really is important for chronic leukemia patients, is leukemia in the COVID-19 pandemic. So back in my day, we didn't have to worry about the COVID-19 pandemic, and leukemia patients specifically didn't need to worry about that. They had enough to worry about otherwise. But unfortunately, that's not the case now. So early in the pandemic, there was a lot of attention paid to what type of patients are more or less likely to have bad outcomes and die of COVID-19. Because of the common nature of comorbidities like diabetes and obesity and heart disease, it was pretty clear that those patients were at high risk of infection complications. And those of us who spend time taking care of blood cancer patients knew that other viruses have a profound impact on them, and so it made sense that COVID-19 would too. So early in the pandemic, a number of different groups looked at mortality from COVID-19 infection and found really high rates of mortality. So acute leukemia patients, as you see on the right, these are averaged outcomes from a number of different series all over the world, about a 40% mortality rate, which is just astoundingly high. There's a little bit of bias in these studies in that they really were more likely to include hospitalized patients in their series. So it's probably true that many blood cancer and leukemia patients are not having a 40% mortality. We've also gotten better at managing COVID-19. So I think the numbers are much lower now. But suffice, this is really kind of the best that we've got. And so also identified on the left side of the screen there are particular groups at high risk of bad outcomes and death. Adults do worse than children, that's well known. Older patients over 60 do worse than younger patients. Recent cancer treatment, that makes sense too. They're more likely to be immunosuppressed. Recent treatment tends to do worse than non-recent treatment. And another phenomenon that has been well described in non-cancer patients is that racial and ethnic minorities have adverse outcomes, and that's also true within blood cancers. So that kind of gives you an idea of the scope of the problem. We'll go to the next slide. So why is this? So I think one of the ways that we can think about protection from COVID-19 is looking at responses to vaccines. And so this is a study that was recently published looking at humoral, so antibody responses to vaccine, and T-cell responses to vaccine in different types of cancer patients. On the left of the screen, the darker green bars represent antibody responses in blood cancer patients, and then on the lighter green bars, those are solid tumor patients. So you can see that after the first dose, before the second dose, and after the second dose of an mRNA vaccine, the blood cancer patients are much less likely than the solid tumor patients to develop a protective antibody response. A lot of vaccine studies really haven't looked very extensively at T-cell responses, which are a really important part of the immune response. And on the right, you see some graphs of different T-cell responses to the vaccines in different tumor types. And so interestingly, a number of these different tumor types, you'll see augmented T-cell responses even when the antibodies aren't developing. But there's one interesting exception to that, is that on the very left of that, you see CLL, or chronic lymphocytic leukemia, really has poor T-cell responses. And we'll get in the next slide into why that might be. Outcomes in CLL patients were measured early in the pandemic by Dr. Mado at Memorial Sloan Kettering, who's a CLL expert, and showed very high rates of morbidity and mortality for both outpatients and hospitalized patients with CLL. This was true for both older and younger patients. The older patients did worse. Patients with medical comorbidities, as measured by this CIRS score in the upper right. But what I find really probably more interesting than anything, panel C there, is that even patients who've never been treated for CLL do as poorly as patients who've been on treatment. And this speaks to the unique immune deficiency of CLL patients, some of whom have never been treated. So go to the next slide. And to look at individual patients and measure their antibody response, on the upper left, you see these individual patients across the x-axis and antibody response on the y-axis. And it's very easy to compare those CLL patients in panel A with the normal non-CLL healthy subjects on panel B. You can see that there's a drastic difference in antibody responses. And on the bottom panel C, the percent of responses is about 50% of what it is in controls, and the absolute change in panel D shows that the antibody responses are worse in the CLL patients. So, so this just shows you, that the immune system in CLL patients don't respond to that challenge that the vaccine is giving them. Looking at treatment history is also important. And the vaccines in panel A here, we see that even treatment naive patients only have about a 50% chance of having an antibody response. The best responders are those patients who've had successful treatments, the green bar, off therapy and in remission. But people who are on therapy or relapsing very seldom develop an immune response. On the very right of this, you see immune responses in certain very commonly used therapies these days for CLL patients. BTK inhibitors on the left, and anti-CD20 antibodies plus venetoclax on the right. Now, these are therapies that directly target B cells, whether they be CLL cells, but they also have the off-target effect of hurting healthy B cells. And so, the B cells make antibodies, and so it's not surprising that therapies that target B cells are, put people at risk for having poor anti-vaccine responses. Go to the next slide. So what can we do for these patients? Fortunately, we are less helpless these days than we were early in the pandemic. This is some data out of a registry from Leukemia Lymphoma Society that looked at B-cell malignancies, which includes CLL, and patients who had been treated with these anti-CD20 antibodies or BTK inhibitors. And it looked at antibody responses to a booster dose, so a third dose of these mRNA vaccines, and found that over half of patients had a response in this relatively small study. Keep in mind that most of the data that we have for antibody responses to vaccines and booster shots in immunocompromised patients come from the solid organ transplant population. So, but this is some interesting data that suggests that our booster shots for CLL patients and other B-cell malignancies are really important tools in protecting our patients. So I would encourage you to have your patients go out there and get vaccinated with 3 doses. In addition to vaccines, what can we do for patients? So as you saw on those previous slides, not everyone who even gets 3 vaccines is going to make an antibody response. And in CLL in particular, the T cells aren't going to do much either. So on the top of this slide, looks like you can't hear me. Okay.
Dr. Foster, you're coming through loud and clear. So
maybe on their end. Okay.
Yeah, we do apologize if you're having trouble on your end, and we will make this recording available later this week for anyone who does miss that, and I'll put that in the chat as well.
Great.
Thank you.
Okay. On the top of the slide, we see a randomized trial of the Regeneron COVID-19 monoclonal antibody cocktail. This was used in patients at high risk for complications as outpatient treatment for mild infection and compared versus placebo. So this is not just CLL patients or not just cancer patients, but other patients at high risk for hospitalization or death. And you can see that this resulted in reduction in the risk of hospitalization or death and has been approved based on an emergency use authorization for that population. Furthermore, patients who've been exposed but at high risk for complications were tested in a randomized trial. So this is uninfected patients, and this is used as post-exposure prophylaxis. Now you can see at the bottom, these monoclonal antibodies have been shown to reduce the odds of having symptomatic infection. So what I try to counsel all my patients, especially with CLL, but with other leukemias, to get vaccinated, get a booster shot, and if they're exposed or if they have a mild COVID infection, to of course get tested and contact us about setting up these monoclonal antibodies in those cases. So this takes us to the final poll everywhere question. So which cancer patient of the below is least likely to mount an antibody response to vaccination against SARS-CoV-2? Oops. Well, looks like we showed the answer, but which is good because everyone's getting it right there. So the CLL patient off therapy. And this is important because a lot of these patients, we think of CLL as a, quote, cancer that someone dies with rather than dies of. So there are many patients even off therapy walking around with CLL for many years that really don't look sick on their surface but are at really high risk. So, so I want to make sure that we remember that for today's talk. That said, that's the last slide, and it looks like we got a couple of minutes for questions. You're always welcome to email me with questions too.
All right, and Dr. Foster, thank you so much. We apologize. We heard one individual had trouble with responding to the poll everywhere. Hopefully, if you switch to another input mechanism, that will work, but I apologize. And similarly, we had one individual, it sounded like, lost the audio. We will have a recording of this presentation available tomorrow for anyone who was not able to attend the entire presentation or was having technical difficulties. In general, it seemed like that was getting out to everyone. And Dr. Foster, sorry for stealing your thunder there. I was trying to respond to the concern in the chat, and Zoom thought I was putting in keyboard advanced strokes on the keyboard.
All good.
So we do have this ready to take questions, and we'll be looking for your questions while we're waiting. If we were to have you back in a year or two to give a similar talk, what would you expect you might be talking about at that point? What do you see on the horizon that you didn't cover today, but that you're expecting to be able to hear more about in the near future?
Yeah, well, I think I alluded to a little bit of that. I hope we hear a little bit more about the magrolimab data in TP53 mutated AML. I think I would like to see more, be able to talk more about longer term outcomes from CAR T cells. In the CLL world, we didn't talk about therapy, but we're in a situation right now that it's kind of an embarrassment of riches that we have many good drugs for CLL, and we don't quite know how to combine them or sequence them, or do we need to give them for a defined amount of time versus indefinitely. There's some really interesting trials going on right now to try to answer some of those questions. So those are some new things, and I would also hope to have, some early phase data from some of the other interesting targeted treatments out there for AML.
Great. Thank you so much. I know, looking at my notes, I know that you mentioned earlier on in the talk talking about side effects of oral treatment in the inhibition of CDA with oral therapies. Was when you were able to overcome that with another medication, were there any side effects to actually inhibiting the CDA?
It's a little bit hard to separate the side effects of the sadurazidine versus the decitabine. I would say that in general, the side effect profile of the oral agents is somewhat similar to the IV or subcutaneous agents, and those being, suppression of the bone marrow function, risk of infection, and GI toxicity as well.
All right. Well, thank you so much. I want to make a couple of closing remarks, and then we'll check for any other questions. If you also want to drop a question in the chat, you are welcome to as well. We do want to thank the people of North Carolina for their generous support of so many things, including the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, including Mary King, Veneranda Obore, John Powell, Oliver Marth, Jason Paler, and Andrew Dodson, each and every one of them for all of their contributions to this.